Test, test, 1, 2, 3. Test, test, 3, 2, 1.
Test 1, test 2. David, please test.
Test, 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 test.
Thank you.
And this meeting of the Board of Managers of Tarrant County Hospital District is now called to order. Welcome to all of you who are participating. I'm pleased we are now able to meet by means of electronic participation, thanks to the emergency orders of Governor Greg Abbott and Attorney General Ken Paxton dated the 16th of March 2020, which have temporarily suspended certain requirements and provisions of the Texas Open Meetings Act. Though we are not all able to physically be at the boardroom, most board members, if not all, are participating today by video conference using the WebEx web conferencing application. This is our fourth meeting by this means. So I'm asking all of us, board members, JPS staff, and the general counsel for Tarrant County Hospital District to be patient and do our best to make this smooth and effective as can be. And then I have to call the roll. It's like being back in high school. I gotta find my list, guys. Okay. Dorothy DeBoe.
Present.
Roger Fisher.
Present.
Charlie Powell.
Here.
And Arizola.
Here.
Reverend Ralph Waldo Emerson.
Here.
D.T. Wynn.
Here.
Steve Montgomery.
Present.
Trent Petty.
Here.
Steve Simmons.
Here.
Jim Zimmerman.
And the best for last here.
I'm here. All right. Go away. We'll do this just as we did before. If anybody wants to propose a motion, just either raise your hand or just start speaking, but try and be appropriate for the people that are speaking before you. And then, having said that, is Leanne going to give the opening pledge, Robert? I mean, the opening prayer?
She is. I believe Leanne is on. Leanne, if you're on, if you would begin our prayer, that would be great.
I will. Thank you. So good to be with you all. Will you please pray with me? God of our understanding, we ask for all the lines who are serving with courage and vulnerability. We pray for safety and protection. For all who are experiencing uncertainty, fear, and anxiety, we pray for peace of mind and spirit. For all affected with COVID, we pray for comfort and healing. For all suffering from systemic injustice, we pray for right action and sustained change. For our brothers and sisters around our community, our country, and our world, we pray for shared solidarity. For our board members and JPS leaders, we pray for wisdom and guidance. During this time, may JPS, the #1 hospital in America, be a sign of hope, of comfort, and of love to all. Grant peace, grant comfort, grant healing, grant hope and joy. Be with us always, especially now. In your holy name we pray. Amen.
Amen. And if everybody would please join me with the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America
And to the
republic for which it stands, one nation, under God, indivisible,
with
with
liberty
liberty and justice for all. Excuse me, I gotta turn this bugger off.
Mr. Chairman, I think that's the only time I've ever had the Pledge of Allegiance to George Thorogood's Bad to the Bone.
Well, we are pretty bad, you know.
That's true.
Okay, approval of minutes is the next thing. I mean, citizens, do we have any that Neil knows about?
I don't believe we have any citizens wishing to speak virtually, and we have none in the OPC that I'm aware of.
Okay, because I was not told about anybody.
No, we do not.
Next is approval of minutes, Board of Managers, June 11th, 2020.
Dr. Weber, there is a correction to the minutes. This is Cheryl Hurd. I was actually present at that meeting, but I'm not listed under other attendees.
Robert, you'll take care of that, get it?
Sir? Yes, I will.
Mr. Chairman, this is Charlie. With that correction, I'd make a motion to approve the minutes as presented June 11th. This is Zim, I'll second.
All right, any discussion? All in favor, please say aye.
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 Once again, anybody opposed, please raise their hand so I can see it. The next one is I have is a board chair report. And I've got this divided up into some sections, and there'll be a little bit of out of order. The first thing I want to do is apologize to Trent Petty and Angie Morgan for me leaving them out of the discussion of strategic planning a month ago when I mentioned it. I opened my big mouth and I did not give credit, especially to Trent, for all the time he has used to study, develop, promote, and champion construction projects that help us deliver health care. Trent has spent days, maybe weeks, and maybe years on the Bobbin program and tirelessly through everything up to recently the search for the program management services. I did not mention those when I made a comment about strategic planning. And Trent, please, I hope you'll accept my apology.
I had not even noticed I wasn't mentioned, but yes, I do accept your apology and I appreciate it. And that's a very nice introduction. I feel like I should be standing and saluting or something.
No. Okay, number two, the ad hoc committee on legal services met on the 7th of July. The agenda and meeting were put together by Alex, the acting VP of Human Resources. I'd say his last name, but I'm afraid I'll just butcher it. I mean,
It is Dubuclet.
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 Dubuclet. We agreed on the process and we agreed on various areas that should be topics of questions for each candidate. Alex will do the initial analysis and then we will meet as an ad hoc committee of the full 5 to interview and discuss. Ms. Regina Montoya was kind enough to already give us the names of 5 candidates from the local area that would be suitable for what we're looking for. And I want to thank her for her efforts. And I believe we're planning to get going on this week after next. And then the third thing is Rob Stevenson in the audience there?
Is.
Rob, can you go ahead? Rob and Michael were left off the agenda and they should have been on it. So Neil said that I could do this under the chairman's report. Rob, could you give us an update on the PSI 90?
Yeah, I think we have some slides. So if we could go to the slide deck on PSI 90. Jeffrey, you got that?
Yeah, he's working on it right now, Dr. Stevenson.
Appreciate it. Thank you.
We're not going to have a quality meeting next week, and I want to make sure that the quality efforts stay right up in front of everybody.
Here we go. Yeah, we can start here. We don't need I don't think we need the title slide. Okay, next slide. So we continue to do well in PSI 90, which is our quality goal. So we had another high month in June, but actually, as it turns out, this may be our only COVID impact on our PSI 90 goal, actually, because in the month of June, as you can see, we went up a little bit. And on the next slide, you'll see, actually, it'll be a couple of slides from now, but next slide, please. Yeah. So we continue to perform well in most of the key areas. Our post-operative respiratory failure remains very, very strong, 1.68 For the data that was collected for our most recent leapfrog score, this was actually a value of 8. So we've improved from a ratio of 8 down to 1.6. And our overall rate for PSI 90 is at 0.85. The other notable move, as you can see, is that we've moved our DVT PE rate from 3.27 to 1.57. So that continues to perform very, very well. Sepsis also very significantly improved from fiscal year 19 to 20, 4.58 to 2.8. So those areas have been strong positive areas of movement in this fiscal year. Next slide, please. Oh, sorry. I thought we had the slide of what the events were in the past month. What I will tell you is that we had 3 DVT PEs, and 2 of them were in COVID patients who had been in the ICU for long periods of time. So those patients, especially those patients who came in early in the COVID crisis and were in the hospital for long periods of time, were frequently on the ventilator paralyzed and prone for very long periods of time. And so I'm not terribly surprised that we picked up a couple of pressure ulcers, given how sick those individuals were. So those 2 pressure ulcers may be the major impact so far on our PSI 90 goal of the COVID pandemic. So I just wanted to bring that to your attention. But overall, the PSI 90 work continues to go very, very well. And eventually that should play into improved performance in both Leapfrog and CMS Star.
All righty. Anybody got any questions for Rob? I don't see any, Rob.
Okay.
Thank you very much.
Thank you, Dr. Weber. I'm going to be doing, at least kicking off the next part of it as well, just so you know.
Oh, okay. Well, I was going to introduce Michael to talk about COVID-19. Are you going to be handling that?
Well, he's going to give you the analysis, but I wanted to show the board. I actually showed some of this. Well, I wanted to show the board some data about where we really stand in Tarrant County and Texas, and then in JPS with regards to the COVID pandemic, as we compare to other locations in the world, and just give you a sense of what we've been seeing, and then let you know what we've been doing about COVID, and then Michael will put that into context for everybody.
Okay, go ahead.
So I'm going to go ahead. So next slide, please. So this is where we stand in the world right now with COVID-19. So you can see that we started off with sort of a linear rise in cases for the first couple of months. And that was as places like Italy and Europe were getting hit, and we were starting to see cases. And now you can see as some of the larger locations in the world, like India and Brazil, and we'll show you that data, are seeing cases, and we remain pretty strong in seeing cases here in the United States as well, that we're seeing some acceleration in that curve. And so we're now sitting at about 12 million cases in the world at this point in time. Next slide, please. This is our curve in the United States. So you can see we have about 3 million cases. You can see that we had a pretty aggressive rise as places in the Northeast, particularly in New York, were getting hit hard. You can see then there's sort of a shouldering of the curve that happened through May and into early June. And really since June, thanks to the surge across the Sun Belt, we're seeing very dramatic increases in cases in the United States. So that curve is really accelerating again. Next slide, please. How are other places doing? Remember, Italy got hit really hard. They've introduced all sorts of measures to socially distance and masking, et cetera, and they've managed to bend their curve to almost flat. That's seen really across Europe. Canada also is seeing a similar result right now as well. So it is possible to bend this curve, and a number of places have been able to do that. Next slide, please. This is Russia. They're seeing a lot of cases right now, pretty linear, very similar looking curve to the United States as a whole at this point in time. Next slide, please. Some places are seeing more of an exponential rise. Brazil, for example, definitely exponential rise. There are other countries as well, like Mexico, India, that are seeing similar amounts of of exponential rise in cases where they're really galloping in terms of new cases that they're seeing. Next slide, please. This is a concerning slide. So if you remember, South Korea got hit very hard early with the pandemic, but they responded with aggressive testing, contact tracing, and social distancing. And that kept them in fairly good stead for a couple of months. And now you can see as they've started to open up, now they're seeing cases there as well. So the takeaway from this slide is that you do not eliminate the risk of the virus by social distancing. You can significantly mitigate its impact in terms of people getting sick and dying, but the virus remains. And so this gives me concern that until we see a vaccine or an effective ambulatory treatment for the virus, that it's going to remain a real scourge for us as a global population. Next slide, please. So how are we doing in Texas? Well, you can see we're seeing that exponential rise here. And next slide, please. Similarly in Tarrant County, exponential rise in cases. Next slide, please. And you can see how we compare on this slide to other places in the world. There are a variety of places like New York, Canada, Italy that have bent the curve and flattened it. There are a variety of places that are linear, like the US as a whole or Russia, of course, big countries with a lot of diverse locations. But you can see Tarrant County and Texas, we're tracking with Brazil and India. So we really are the heart of the pandemic right now in the world, right here in Texas. Next slide, please. And you can see here that mortality in our location is generally increasing linearly, which is somewhat good news, but there are some locations as well in the United States, like Arizona, where they're actually seeing an exponential rise in mortality as well. And then there are some places that have managed to bend the curve a little bit. Oklahoma looked like they were bending it, but it looks like it may be ticking back up again there. Next slide. So what have we been seeing here at JPS? Well, we had that big surge of cases from the federal prison back in April and May, but over the last several weeks now, you can see a real surge in admissions coming into our facility with COVID. Next slide. This is a chart of our entire hospital census throughout the pandemic. You can see that big peak in the middle was really reflective of the federal inmates from FMC Fort Worth, which of course is really a federal prison nursing home. So those patients, when they got COVID, got very, very sick and needed hospitalization. And now you can see the rise that we're seeing now, very, very significant acceleration in hospital admissions that is now reflective of community spread, not an outbreak at a contained facility. Next slide, please. This is what's being seen across the Metroplex. So the red line is Parkland. They're up over 150 cases now. Harris is at 120. Bumpsy is at 113, and we were at 108. We've now crossed into the 110, over the 110 mark as of today. What's important to know is that, and I'll explain this later, but we actually have an outpatient case management program, and right now we have 38 patients in that program on oxygen. So we would be over 150 today if we're not for that program. And Michael will describe that program in a lot more detail to you in a little bit. Next slide, please. So this is our ICU census. Again, we got hit hard with the federal prison nursing home in late April, early May. Again, these were patients with a lot of comorbidities in a federal prison nursing home, but you can see that ICU volume is beginning to accelerate again. Next slide, please. So as you may have heard, we saw when the cases started to accelerate in June, a lot of the patient population that was getting affected were younger people. And this is not surprising because as we opened up, the people who were taking the least precautions were our younger members of our society. But when we saw that data, we were pretty sure that those individuals would subsequently then begin to interact with their parents, grandparents, and others, and we would expect that age to rise. And we've seen precisely that. And so our average age of admission to the hospital now is over 50. And so attendant with that is an increasing need for both ICU care and ventilators. So as we've gotten into an older patient population, we're also seeing people get a whole lot sicker with the disease. Next slide, please. Next slide, please. There we go. We've also seen some pretty dramatic shifts in the ethnicity of people being admitted to the hospital with COVID. Most notably, over in the month of June, we saw a real shift to a very significant number of Latino patients coming into the hospital. This is data that's now a couple of weeks old, and now we are at nearly 80% of our admissions being from Latino people. So that's a very, very significant trend that we've been seeing. Next slide, please. So how likely are you to run into a COVID positive person just walking around town? So we have some insight on this, and we have three populations of patients at JPS that we're testing who have no symptoms of COVID whatsoever. So it's people, women who are coming in to have babies, women who are, patients who are getting admitted to Trinity Springs Pavilion for mental health problems, and patients who are coming in for elective surgery. So our elective surgery patients have been testing positive at a very low rate, less than 1%. The patients coming in to have babies, actually now over 8% of them are coming in testing positive. And the Trinity Springs patients are somewhere in between. So we think that probably the community prevalence right now is of asymptomatic people who are positive for COVID is probably between 1% and 2%. And I'll get into why the women may be higher. Next slide, please. So initially, our women coming in to have babies were testing positive at a rate of less than 1%, but that has really surged over the last several weeks. And we did some deep dives into this, and the common denominator for the positives turned out to be baby showers. So they were having baby showers, all getting together, and of course that's a very intimate thing, and a lot of embracing and eating and all that stuff. And so that seems to be a specific risk factor for our women, our pregnant patients, is having baby showers. So we've actually undertaken a real effort to encourage women not to have baby showers during this time of COVID. Next slide, please. So what have we done about COVID? An incredible amount of work, really. So we stood up the hospital command center. We launched a clinical steering team of our business leaders and some operational leaders to really try to understand all the recommendations out there, data, et cetera, to try to make to give our organization the best guidance as to how to do PPE, how to really understand testing. All the different protocols that we've created have come out of clinical steering in terms of that understanding of those guidelines. We have come up with defined surge and de-escalation plans. We have aggressively sourced testing reagents, PPE, beds, respiratory therapy equipment, pharmaceuticals, staffing resources. We stood up a dedicated COVID-19 ICU, as well as a step-down unit, dedicated med surge units, and for a time we had a dedicated COVID-19 inpatient psychiatry unit as well. We now, because of our testing for admissions to Trinity Springs, we don't need that unit anymore. It's been a real success story. We have, as I mentioned, a phenomenal outpatient case management program. We've also created a state-of-the-art COVID-19 post-recovery clinic, which includes pulmonary medicine, internal medicine, psychiatry, because our patients who've been in the ICU for a long time have real issues with PTSD and other very significant psychological issues, as well as social work is there, and as well as financial counseling, because the disease has been so devastating on some of these individuals' lives. We have some phenomenal COVID-19 dashboards, which has allowed us to keep track of everything that's going on in real time. We stood up entry screening right at the beginning. As you all know, we have a COVID-19 hotline, which has allowed our employees and others to get critical information about the disease in real time, and also determine whether or not they need to be tested. We've stood up drive-up testing for our ambulatory patients and employees. And of course, we've had a central role in the management of COVID-19 in our homeless population. And related to COVID, but not directly, has been a tremendous effort around telehealth, where we have been able to continue caring for our patients, even as we've not been able to have all of our clinic locations open. And we've shown tremendous capability to continue as a very highly productive organization with many of our employees working from home. So with that, I'll turn it over to Michael for his comments, and then we'll be happy to answer any questions. And I really
Thanks, Bob.
appreciate the opportunity to present this information.
So thank you, Rob. It really has been an enormous work effort that's occurred here. Can everybody hear me and see me? Just want to make sure.
Yes.
Great. So, it's been an enormous work effort, as Rob has articulated. Where we are today should not necessarily be a total surprise or shock. As we've talked about before, just as recently as last month's board meeting, the month of June was going to be extraordinarily informative for how far we had to go, or to really get insight in how far we really had come during those early months of the pandemic. And as we learned, right into the middle of June, we started to see cases rise. And certainly that month of June was going to provide that information because it tied directly to a variety of things, reopenings, Memorial Day weekend, holidays, people starting to return from their shelter from homes. And in those first couple of weeks within June, as we saw this spike, the majority of the population was really coming from a younger patient population that was COVID positive and symptomatic. So for those less than 40 years old, we were also seeing, relatively speaking, a lower acuity on those that were going to require hospital admission. And there's any number of reasons why we might have been seeing a lower acuity. Part of that is certainly an increased comfortability in managing COVID positive patients. And the example that I frequently give on this is in New York in the early days of the pandemic. One of the first lines of defense was putting COVID positive patients on ventilator support. And as we have learned through science and through the data, that is really one of the things you do as a last measure of resort, because these patients can tolerate lower levels of oxygen in their body. And we also have different modalities such as proning, where a patient is lying on their stomach, which alleviates pressure on the lungs. And so we are more comfortable in treating patients. We have got better treatment options. And we were seeing patients coming in sooner. However, the concern was not that we were necessarily thinking that the young patients and lesser acuity would be where the future would lie in COVID, but rather would the potential be that it would be a false narrative? And would that end up being a red flashing warning light because we hadn't yet seen older patients or those with more underlying comorbidities? And that's exactly what we started to see in the last week and change. Our average age now on COVID positive patients being admitted into the hospital is over 50. We are seeing more patients requiring ICU level of care again. We had held at a relative steady state on our COVID ICU really since March and April at around 9-10 patients. A little spike when the Federal Medical Center was here. We had gotten up to around 18-19, but we had held through May, through early June at around that 9-10 number. We've got 16 in our COVID ICU right now. And overall in the hospital, we are sitting right around 111, 112 COVID positive patients. And I think there's a very, very high likelihood that, we will hit 120, we will hit 125. And that could come in the next day or two if we maintain the same rate of admissions. As we've done throughout the entirety of this pandemic, we really have looked at this in 2 to 3 week blocks and intervals. And the reason why that's important is when you think about the transmission rate, as well as when individuals have the potential to start to become symptomatic. And that's usually somewhere between 5 to 7, 7 to 10, or 10 to 14 days after first becoming infected, with 14 days being really the outermost limit. And so every 2 weeks gives us further insight in terms of where we are, how far we've come, and how far we really have to go. We anticipate that our COVID units, including the ICU, including our intermediate care, are going to be with us for the foreseeable future. And we did the absolute right thing and the smart thing that we kept those units open and operational through the month of June. But we certainly anticipate we're going to have them through the summer, into the fall, and into the winter. But I think we need to be prepared that for the next 18 months, there's going to be, in all likelihood, COVID positive patients. What that number actually looks like, I think, is too difficult to forecast at this point. And it may be herky-jerky and starts and stops. But short of COVID totally petering out like swine flu once did, short of a vaccination, and the vaccination comes with its own challenges. It's getting in the hands of individuals. It's being safely tested. Those are really the two most likely things that will really substantially reduce COVID spread. We know that universal masking, we know that social distancing can flatten the curve, can help mitigate disease, reduce those numbers. But there are things that ultimately can halt this in its tracks. As Rob mentioned, we would probably have more COVID positive patients in our hospital right now if it wasn't for the success of our outpatient case management program. That has really been a game changer for us. And we have gotten other institutions interested in our outpatient case management program, but we would probably have the same numbers that some of our community partners have, from 130, 140, 150 COVID positive patients if it wasn't for that program. We currently have 200 patients enrolled in the outpatient case management program, 40 of whom are on oxygen, 160 that are off oxygen. That 200 patient population receives multiple daily phone calls a day, multiple daily check-ins a day. And we estimate that over the life of the program, which has been in existence since end of March, beginning of April, we have saved about 2,000 hospital days, because certainly the patients that require oxygen would have all likelihood been in our hospital. And so we have been really successful in working across the network, in breaking down silos, in having and following what the literature says, what the data shows, what the science points us, and not reacting and responding to every social media post, every Facebook video, but to really be deliberate and vigilant around our care, our services, how we deploy resources, and how we develop and strategize moving forward. And so with that, I will stop there. And Rob and I are certainly open to entertaining any questions anyone may have around quality, PSI 90, or our state of COVID.
Michael, on the outpatient program, are other hospitals or systems using that same program?
So not to our knowledge. We know that we have Steve Davis, who has been integral in getting that program up and running, along with Dr. Alawi and Dr. Assad, has fielded queries from other hospitals asking for what the program is and how it gets implemented. Some institutions may have variants of it. I know that there are some New York hospitals that were doing similar things. But to my knowledge, we are at the very least one of the lone institutions doing it here, and we have had a huge amount of success with it.
The increases in the Latino population, I contribute directly to the construction industry because the construction industry has been hit hard in the last 3 weeks. That's just a personal rant of mine. I'm not very happy with it. Did y'all track any statistics on the homeless population? Because it seems to me that population would be completely decimated. And I'm just curious to see if there's any stats that would back up that hypothesis.
So from the homeless population, we were staffing the convention center when it was open and operational. That was in the March, April, May time period. We were not seeing any substantial differences in the homeless population compared to what we were necessarily seeing in the community. And when we look at our patients in the hospital right now, we are not seeing any substantial outliers consistent with the homeless population.
Is the convention center still set up?
I think that they either still maintaining it. Go ahead.
Michael, this
Yeah.
is Karen. Steve, Roger, I'm sorry. I can answer that. The convention center came down about a month ago, and so they are in town. I want to say they're in the townhome suites. So they moved them from the convention center to a hotel that was empty. That convention center, I don't know whether you were on the presentation that Joy Parker made to the board, one of the Wednesday board presentations, but it really was able to allow the shelters to practice social distancing. And really, I think it was instrumental in a lot of the homeless not testing or being treated for COVID positive. They actually had trailers outside of that convention that they were able to allow the quarantine when they did designate a positive homeless patient with COVID. And we were even able, if they were seen in the emergency room and were asymptomatic, to follow them there. And the TrueWorth physicians under Dr. Lonergan have been able to visit at the convention and continue to visit at the townhome suite.
Have we seen an increase in that population with the current surge that we're seeing across all the other populations?
I will let Rob and Michael speak to that, but we are not seeing that at all. And I think it really has been our ability to do that more like a nursing home and to really be able to screen them in a place and to practice the social distancing.
Yeah, we have
five
homeless positive patients currently, which again is not sizable, but certainly, Roger, you are 100% correct that the homeless population is extraordinarily vulnerable during this time period. And as Karen mentioned, we were significantly leading the initiatives around maintaining social distancing, allowing and providing an environment for our homeless population to be safe during this. But they still remain, absolutely correctly so, an at-risk population.
Cool. Thank y'all for your work. Suzanne, do you think that we could get a copy of that presentation on the board portal?
Yes, I will send it
It's
out.
not already there.
This is DT. May I make a suggestion? It's nice to see the data from other countries. Is it a possibility that we can add or replace one of the country with Sweden? The reason I'm saying that because that is the only country that doesn't practice social distancing and doesn't have any shutdown whatsoever. That may give us some early indication for our homeless population if we can extrapolate somehow, because it's kind of free falling by itself.
Yeah, I think we can certainly do it. And, Sweden, when you look at their on their mortality rates, are definitely higher than other countries. And even their rates of infections are starting to rise substantially. And part of the reason Sweden initially said is they were concerned that if they shut things down, it would impact the economy, it would impact kids learning. But they've actually seen just as much drastic changes to their economy, even in the face of not shutting things down. The other comments is, you mentioned Sweden and mortality rates. One of the things that we have consistently also heard recently is, mortality rates are less. Mortality rates in general are a lagging indicator. They will follow after patients get admitted into a hospital. They will follow after the patient's admitted to the ICU. So I think it's too soon to tell what this current spike may end up looking like from a mortality rate. What I do anticipate, and what has at least continued to be proven out, is that when all is said and done with COVID, and when all the studies have been written and the epidemiology is done, I think we will see a high transmission rate. A lot of people that were walking around asymptomatic or mildly symptomatic, overall a low mortality rate, and relatively speaking, a low to moderate virulence. But when you consider a large population, even in the face of low mortality or low virulence, that's still going to be a substantial number of people that will get infected and get sick and require hospitalization.
Right. I'm just merely saying, although we want to go after, I'm just saying that should we be looking at their growth of cases and all that stuff, kind of give us the indicator for how a homeless population, where we literally, they don't have information on that stuff, it's kind of free falling type thing. Just give us an early warning or something to plan ahead. I'm not saying that that's the model we want to go after at all, but just, for us to see, is that going to be rise to the level where it's very, very dangerous that we need to take a look at something differently for that population?
This is Trent. I have a question, maybe Rob, maybe Michael, I'm not sure. Do we have anything that illustrates what JPS mortality rates are compared to other facilities as they treat COVID?
So we certainly have our mortality rates. Rob, do you know on the data that we pull on hospitalizations, does that also include their mortalities? In total, we've had 40 deaths across all our COVID positive patients. To date, we've done about 8,000 tests. We've got about 1,600 patients in total that have tested positive. We've had 40 deaths, most of which came early in the April-May time period related to, as we saw higher acuity coming in through the door. But Rob, I'm not sure if we've got the reported mortality from some of our other local hospitals.
Yeah, I haven't seen it from anywhere else. I mean, our mortality rate of hospitalized patients, we've admitted about 600 so far, and we've had the 40 deaths. So we're, about, 7%, something like that, overall mortality.
That's mortality of hospitalized.
Correct.
Look at mortality rate. We've got to look at it across all patients that have tested positive.
That's right. And that's absolutely right. But, remember that our testing has been very focused on patients who are symptomatic or patients who were, are high risk for some reason. We have had some, as you saw from the data I shared you on, some asymptomatic testing, but that's been relatively small, a relatively small piece of our overall testing situation at JPS. So most of the patients we've tested are symptomatic. And so the mortality of basically of what we would expect in terms of total positivity to mortality would be way less than we would see from our testing data at this point.
One more follow-up question. Among you medical professionals, is there anything to the notion that maybe as a county, maybe as a community, we should be wholesale testing everyone as a requirement because of the number of asymptomatic spreads that we're getting?
So this is my perception of testing. So the challenge with testing is unless you're able to test everybody all at once at the same exact time, a negative test by itself always the potential possibility to give individuals a false sense of security, right? Because a negative test today does not connote a negative test tomorrow, or you could actually not just be, you may not be generating enough virus to actually be picked up on a swab, and the next day or 2 days, you could eventually then turn positive. It's definitely informative from a positive standpoint because those individuals you can try to do some contact tracing on, you can do quarantine, but even positive testing in an asymptomatic population, you don't know where they are in their level of infectivity because we have seen, and the data and the science is showing this, that someone could be positive for 2 months, 3 months, and it's really either when they're symptomatic or when they're doing some form of viral shedding. And you could be asymptomatic and doing some form of viral shedding. And so it's hard even to say what a positive does, short of you do have the capabilities to do some quarantine. There are CDC guidelines about once an individual tests positive, for how long you should watch them, monitor them for symptoms before you can say they're clear. So it certainly gives information. The negative ones are the ones that are a little bit trickier because of the challenge that individuals may wear that as a badge or think it's a shield and that they're safe now.
Thanks, guys.
How are we doing from the reopening of the elective surgery and all that stuff?
Sure. So we've held in phase 1A of our elective surgeries. And so that was defined as individuals that were low risk, would not require hospitalization. And we've expanded the criteria very slightly to include potentially longer procedures. But we are still doing phase 1A elective surgeries, which is about 110 cases per week, and is not yet, and hopefully it won't, tax the system because these are patients that are not going to require admissions. We have enough PPE stock, and we have enough staff to manage through. We are not going to extend into phase 2 at this point because phase 2 then is patients that would require hospitalization. And at that point in time, you do get into a potential resource squeeze. And obviously, we continue, though, regardless of admission or not, if this is an emergent or urgent surgery. So those are surgeries that cannot be postponed because they will be because of potential harm to the patient. Those patients we have continued to do throughout the pandemic, and we continue to do now. It's on the elective side, which is defined as those medically necessary but time-sensitive procedures that we are continuing to do it, but only doing it right now for patients that do not require an inpatient stay. And we still have our community health clinics open in their phase 1, 1A, 1B state, so that we can continue to provide the appropriate access and resources to all patients in our community.
Hey, Mike, Mike, this is Charlie. I just had handed me, and I'll let Robert or Karen answer this. It was just handed me at 1:30. It says the governor just expanded restrictions on elective surgery in 11 more trauma service areas as of just a little while ago. So I haven't read the whole proclamation, but apparently they're doing more restrictions across the trauma service areas.
Yeah, I'll take a look at that. The governor's executive order from a week and a half ago, which may now be extended to those other locations, did exclude ambulatory surgery centers, did exclude outpatient procedures, and also had the caveat in there that as long as it did not tax one's resources.
Right.
This is Reverend Emerson. I have like 3 questions. I'm going to ask them all 3, and then I'll sit back and listen. One is Dr. Stevens mentioned earlier about on the Latinos and the spike in that and the baby showers. Do you have an average age range for that population with that spike? Do we know what was it a lot of younger individuals or seniors in that group? The other is
sorry, sir.
He talked about the baby shower. So is that something that you are saying to every mother comes in, or is that some material that you're handing, advising not to do baby showers? And I'll explain why I'm asking that later. So I'll let you answer those couple of things, right?
So the answer on the Latino patients is that the ages have tracked with our overall population. So when it was younger, but now it's getting older, right? So those young individuals who were getting infected in early June are now infecting their parents and grandparents and others. And so we've seen a bulk movement in especially right now, since nearly 80% of our patients who are being admitted are Latino. They are tracking with the rest of the group. They are the group. In fact, the others are outliers at the moment, if you will, when you've got 80% coming from one ethnic group at this time. As far as baby showers, my understanding from Dr. Sanga is this has become a real focus of our OBGYN department. They're really strongly encouraging. I don't know whether they're handing anything out. I don't have that detail, but I did ask her on the basis of this data what they're doing, and that has become a major area of focus for them.
Can I also interject just for a second?
Yes.
On that, especially with our Latino population, when looking at the total base of the Latino population for JPS, we make up about 40%. So we will see that higher base coming through. And I will agree with Roger, Latinos are mostly essential workers. And I applaud the communications team for sending out that information as well about the numbers that it's affecting our Latino patients at much higher rates.
Yeah. There's no doubt that, that the nature of the work that many of our Latino neighbors do is at the root, whether it's construction or other essential work, because it's way more than just construction. It's very broad based, and they are at risk out there, and they're getting hit really, really hard, and it's tough to see. Honestly, it's really tough to see.
Okay, I was asked to serve. I don't know how in the world I got involved. But I was asked to serve on a community advisory, I don't want to say board, I think it's a committee. I think it's Harris and UT Southwestern that's pulling that together, that's dealing with the underserved and minority populations as it comes to dealing with the spike in COVID with the minority populations. So I had my first meeting on yesterday, and it's about 20, 30 persons in that group and it's a cross section of individuals around the Dallas and Fort Worth that are part of that board. So that's when I add my question on that. But on the who's the determinant that determines the testing sites? Who says where the testing sites are set up, and that there'll be a testing site?
This is community wide, or is this at JPS?
Period.
Okay. Well, I think we can only speak to JPS, but we have availability of testing throughout the hospital. We test in our emergency department, and then we have really for any of our ambulatory patients or employees, we have set up a drive-up location. It was originally at Luda, now it's at Viola Pitts. And so we direct our patients to getting tested there. But beyond that, community-wide, I don't have that information.
Reverend Emerson, I can speak to that. Where it has gone in the past in Tarrant County, and it's very similar in other counties, is county government plays a key role in that. So testing centers for community purposes have been defined and allocated by the county commissioner's court, and also the University of North Texas has played a role in that. They've partnered with the Moncrief Cancer Center, and it really focuses around those who could come to the plate with testing capabilities. Moncrief had some capabilities, UNT had some capabilities, and the county said, you bet, that would be a good idea to put some of those up. So mostly that's going to go through the public health department in most cases. The curiosity or the confusion that some people have is we here at JPS have we have to be cautious with our testing capabilities. So we obviously test our patients, our employees, and those that are coming through the door. So employees, patients, and is the likes of what we do. But other testing centers may be open in the public, but it's really going to go through public health.
Oh, okay. The reason I asked that question too, because there's really a lack of understanding in the community, because many people think that the testing sites are determined by JPS, because of county hospital.
Right.
And I just think maybe some kind of way we need to get something out there, market to help the community understand. And then it's something that Michael mentioned also about the stages of surgery. I don't know how we're doing that, but it would be good, I think, to help if it's some PR piece that explains the stages. This stage, we're doing surgeries. This stage, we're not. We're putting it off, so that individuals are understanding it. Maybe the patients themselves are told, but I'm not so sure that everybody's grabbing hold to understanding what that process is.
Well, your points are well taken, and I know our communications team is going to work with Michael and others, and we've obviously put information out, but getting more of it out is really important. And a lot of that is also going to come through your specialist and your primary care doctor, and they've been really good at getting information out so far, but got a long way to go. So I appreciate your comments, and we'll definitely work on that as well.
Yeah, if I could offer some assistance with that, I think that even if it's of elementary nature, as an example, I'm part of a large group of pastors. Is that and at the board executive board meeting, that is something I could say to the executive board. Hey, look, these are the steps for this, or some material we can give them that those pastors then can talk to their memberships about that and get so they can get a clear understanding on what's taking place.
Yes, sir. Yes, sir.
Even with Dr. Stevens, when he talked about the baby shower, that had really put a light bulb in my head, because as an example, we used to have a monthly newsletter. We've gone from monthly to a weekly letter from the pastor's desk. And we give updates on COVID, we give updates on sheltering in, and that would be something really key that we need to send out to our membership because of the large young adult population we have in the church, that we could get that kind of information out.
That's a good point.
One other thing that I would like to mention on top of Reverend Emerson's discussion, and especially with the information that we've been given here, and when we're talking Latino population and other populations as well, multi-generational housing. We have to do a better job at educating to take care of COVID patients in a multi-generational house. We have to also remember the fact that many of our county residents don't have the luxury to leave somebody alone in a room. So how can we be that fountain of education and utilizing those types of resources as well for our multi-generational families that are going to continue? If we're looking at an 18-month window or longer, I think that that's what we're going through. I do commend JPS. I talked to David Mendenhall yesterday about kind of the oxygen program as well, the KIT program, the home monitoring program. So y'all have done a fantastic job in being able to put that together. We want to let the community know also what the capacity and capability of that is looking like, and be comfortable with that kind of telehealth, telemedicine, and not be fearful for their sick loved one in the home. They're going to be, but we know that in looking at the numbers of 40 individuals who are on oxygen now, 160 off of oxygen, of what those numbers really look like. The other thing, and circling kind of just back around to the homeless population, we also not only have those that are sheltered, but we also have a large community college homeless population as well that are couch surfing. So we know that that spread is happening as well, that works through and seeing what are coming in through the doors. But, so just kind of looking at what is capacity and what can we do in community health, and how can we work with public health to continue those types of education. It would be great to do some type of webinar educational resources in different languages for families on how to care for their loved one within their home.
Yeah, Amanda, on that point about on the outpatient case management program, we are actively in the process of recruiting more outpatient case managers so we can expand that program substantially.
Thank you.
Any other comments, questions for Rob or Michael? I'd like to just give you my perspective, and I'm just going to use Cheryl Hurd, Michael Hochberg, and Rob Stevenson, but there's thousands of other people involved, and that is the leadership that you guys have shown in the medical group and the medical staff, and all the efforts that you have gone through to provide good health care for the people that are still ongoing, as well as the COVID-19 patients. And I say thank you. Well done.
Amen.
Then I have one last little thing here, and I'm going to give it back to Robert. And this was just some thoughts from last night. There's actually two things. I saw a little thing on the internet that said, it used to be in the automobile industry and the police, it was ticket or click it. I mean, ticket or click it or ticket. Somebody put on there, mask it or casket. What the heck?
Yeah.
What I'd like to say is emergent and urgent care volumes have decreased, and we fear the public is reluctant to seek medically necessary care. Lack of some form of care may be life-threatening. Even in the midst of this viral epidemic, JPS Health Network and its folks continue to provide care to those who need it. Do not be afraid to come to the emergency room or the community clinics. This viral epidemic has frustrated many of the caregivers as they continue to provide care. If you are ill, please come to the hospital. We strive to protect staff and patients. JPS is an organization that constantly evolves to treat a very diverse group of patients from very diverse communities. Every day, we strive to be a trustworthy, compassionate, skilled organization that provides reliable, quality health care. And thank you for the privilege. And Robert, I'm giving it to you. CEO report.
Thank you, Mr. Chair. I appreciate it. I want to give you all and the listening public who are streaming an update on where we are today, or where we were this morning. We changed by the hour, but we have 112 COVID inpatients. That is an all-time high for us, and that is 13 additional patients that we received overnight. We have, that's 16 admissions over the past 24 hours. We have 14 in the ICU, and we have 6 of our COVID patients on ventilators right now. We are not in short supply of equipment. We are not in short supply of ventilators or PPE. It is challenging, though. Our numbers are growing. I am now back to talking to my CEO colleagues now 2 and 3 times a week. And the numbers at Baylor, Medical City, THR are all going in that same level, the same increases. We are all beginning to see those. We are becoming as prepared more every day, obviously. Wanda and her team have worked diligently along with Michael and others and Karen on a surge plan. We have surge plans in place. We update them constantly as we try to figure out the best way to go. So there is not a situation where we are alarmed, but we are seeing numbers going obviously in the wrong direction. We want to do the best that we can. The other challenge that we have is with personnel. It's hard. Our employees are getting weary. It's difficult. And it's hard on our nursing team, and it's hard on our physicians, our nurse practitioners. We have real challenges in trying to deal with the personnel issues we have to deal with. But we will continue to do so. I know that the other hospitals are facing the same issues. So when you talk about where's the future of beds, you have to parallel that with a discussion of where's the future with personnel. If, for example, we have a facility in town that is not currently being used, that may have been a previous hospital, and you want to refurbish that and bring it back up, you can do that, and you can add 60 more beds to the networks. The problem is, and the challenge is getting the personnel to be at each one of those bedsides. So we're working on that with the county, with public health. I had a conversation, in fact, yesterday with Commissioner Brooks and our county judge, Glenn Whitley, and continued to have those kind of conversations. Also wanted to give you all comments about how proud I could be at the incredible nature of JPS and its workforce and you all as board members to be selected by a group at the Loan Foundation Institute and the folks at the Washington Monthly about JPS. And when you look at what you provide in education, what you provide to everybody coming in your front door, whether they can financially deal with their medical situation or not, when you look at the teaching capabilities that we have and educating people for our community for the next 30 and 40 years, when you take all those into consideration, all the things that you as board members have worked hard on, we as staff have worked hard on, and you get recognized for that, that's wonderful. And when you get recognized to be #1 in the nation, it's humbling. And our friends at Parkland to be recognized in the top 10 is wonderful. And our friends at THR to be in the top 20 is wonderful. And we appreciate the colleagues that are on this journey with us, and folks like the Boston Medical, who was also in the top 20, and some of the other great institutions in the nation that do wonderful work. So I want to applaud you as board members for providing the direction and the guidance. And I really want to thank an incredible team that I get to stand next to, from everybody to the folks that make sure the lights come on in our plant ops team, to the EVS team that make us look clean and shiny, to the neurosurgeon who corrects ailments. We are an incredible team, and I just want to thank you all as board members. And we've gotten an immeasurable amount of emails and texts and congratulations. And it's nice to be recognized in that way, and the community recognizing us as well. So, Mr. Chair, those are my comments, but I really have a debt of gratitude to the people I'm lucky enough to work with.
Robert, I just want to mention, since I'm part of the ex-team captains, and I say that because of board chair, ex-board chairs, former board chairs. I mean, it makes you feel good to have been a chair while you have led the hospital. And to see this, what has taken place. Actually, when I read the article and saw it in the paper, I just knew at that moment Karen was going to show up at your office and say, "Thank you, Robert."
Mm-hmm.
I can remember first coming on the board, and while on the board, I can remember that I purposely moved my seat over a chair because Karen was so tough on the patient SAT scores and the scores that were going, that I said, well, she might just turn and tack me too. But I just think it's to be commended because I've gotten calls from around the country congratulating JPS for what has taken place. And really, I am thankful that you have been the person that has sat at the helm as we moved from where we were to where we are. We cannot say it was 3 CEOs or 2 it was one CEO that this took place under.
You're very kind, and you've been an incredible partner, and all of you have been for me. You've given me guidance and direction, and I hear Karen Van Wagner's voice every day. She was a powerful, powerful person. She was a person that would bring you to your knees in fear and raise you to the heights of praise within about 4 minutes time. And she would make you dizzy sometimes in that regard. But you're right about Karen Van Wagner. The other thing is you, Reverend, and Trent, and Chuck, and so many of the others, Steve Montgomery, that put into place a lot of what we're doing. DT reminded me last night, when you look back at our strategic plan that we were working on and some of the workshops that we did, Reverend, when you were chair, it's interesting because we had goals to be recognized, just to be recognized by organizations, and to be recognized as the #1 hospital and working network in the nation is really powerful. So to you past chairs, I really owe a debt of gratitude, and to Karen Van Wagner, she is very much a part of this board. She left us way too soon, but how powerful she was to me.
Hey, Robert, this is Charlie. I just want to add one thing. And you know, having chaired that board the last 3 years, I got a lot of calls likewise, like Ralph was talking about. But if the board hadn't read the full article in the magazine, I have a copy of the magazine, read the entire article. And you and I have had a lot of discussions over the last 10 years. I think your use of the word nice is good, but I think the word deserved is well also. So to you and the entire team, a well-deserved recognition.
Thank you, Charlie. Thank you very, very much.
And go ahead.
No, I'm done, Mr. Chair.
Well, I wanted to let you announce that one, and congratulations.
Yeah.
Thank you. Thank you all very, very much.
I have is the report from the medical staff committee requiring discussion, and that's Cheryl Hurd.
Hi, thank you, Dr. Weber. I appreciate the opportunity. I just want to second everybody's words. Thanks for the board for all their guidance. I really appreciate Mr. Early leading organization, all the other executives and my colleagues. I couldn't do this without them. And I wanted to also thank you for your kind words earlier regarding those of us in healthcare, Dr. Weber. Just having been in it yourself, you're fully aware of the struggles we're facing there. But everybody behind the scenes faces the struggles too. We really are in this all together. So I appreciate the fact that we work together as a team and that we can recognize each other's strengths and use them collectively for everybody's greater good. Now, having said that, I'll get right to business. The first item is just a simple change to adding the fasciotomy to the core procedures of the vascular surgery clinical privileges. This was actually vetted by the surgical chair as well, Dr. Miller. You can see this highlighted in yellow in your packet. Page 23 actually has the list of the procedures, and that's the only thing is an addition. And the action item would be for the board to approve this change.
Trent Petty, so moved.
Steve, second.
Any discussion? All in favor, say aye. Those opposed, raise your hand.
Aye.
Aye.
Okay, motion passes. Cheryl.
I only have one other item, and that is for the approval of the Department of Internal Medicine Critical Care Medicine delineation of privileges. And this is something that was also vetted by Dr. Davis and his team. Of course, Dr. Davis is a pulmonologist, but he did training in critical care, and he practices in critical care and oversees the other ICU doctors. And this entire core privilege is something they've revamped and added things to. So there's no highlighted yellow. The whole thing needs to be approved. But as you can see here, we do give opportunities for people under their core procedures to strike through things they do not have necessarily the competencies for. So there's not any issues regarding competency over those procedures. And that begins on page 27 and goes through to page, I'm sorry, okay. I got to scroll to the very bottom, 31. This has also been reviewed by Mr. Adams' group as well.
Steve Simmons, so moved.
Is there a second?
Second.
Discussion? All in favor, please say aye.
Aye.
Those opposed, raise your hand. Can't see it. Cheryl, thank you very much.
Thank you, Dr. Weber. Appreciate it.
My congratulations once again to the medical staff and everybody else that's involved in all this stuff. The next one I have is department update. The agenda was supposedly connections with Sharon Clark, but I understand, Robert, you're going to take this one.
Yes, sir. I'm going to begin this. It's a three-part little presentation. If you all recall at various times on the board, you all have asked various departments to come before you and give brief introductions and some detail about what's happening in their areas. So what we thought we would do is really start out with taking a look at our connection program. When we talk about our connection program, you also have to talk about the issues of population health and the management of your organization and your patient base. I want to let you all know that we as a staff have heard you as a board loud and clear. And I think it's important that we redefine some of the questions and look harder at some of the answers. So what I've done is we collectively sort of put our minds together and came up with some thoughts. And I think this really does address a lot of what you as a board have talked about, but it's also been a continuation of some incredible work that the team at JPS has done. And it's not just an executive team. It is our managers, our directors, and the people that work so hard at JPS to try to figure things out. The questions that I have that you will have answers to as we go on are not quick answers. And sometimes the answer does change. These questions I will put on your board portal so you can look at it and you can then refer to them and say, did you answer this? Did you answer that? Because over time, some will be quicker, some will be longer. They will all be answered. Some of them have answers now. But one of the things, the first question I think we ought to be looking at is, we have any given population in connection, whether that's 10,000, 20,000, 50,000, 70,000, or 80,000 people enrolled in connection. The number is not as important as the access to the system and what we're doing. And more importantly, to the taxpayer and to the patient, what does that cost? What is the cost of care? So as we go through this process, we know that everybody who comes through our door who is a connection patient, we are substantially going to help them meet the needs financially of their healthcare. That's a proud thing that we do. It's what this organization was founded to do. We now have to figure out how we do that as smart as possible. So the next question we need to ask ourselves is, how do we define the total cost of care for a connection patient and a non-connection patient so that we know? That leads to the next question, which is, how do we stratify risk? Any organization is going to look at that. JPS needs to make a concentrated effort at saying, if we have, for example, 3 people that come into the organization, what type of risk are they? Are they a high risk? Are they a moderate risk or a low risk? What are we seeing out there in the needs? And those questions begin to take us into other areas, such as how do we move from episodic care to preventative care? How do we move from, even if you're enrolled as a connection patient, do you overutilize? No idea where that's coming from. How do you figure out in that situation how you go from episodic care just coming into the emergency room? How do you get into the clinic setting? And how do you get into that clinic setting 3 and 4 times a year? How do we test you for cancer care? How do we get you in for the screening testing that you, those I think are critically important. And I think we need to be looking at that and figuring that out. I think the other thing that we need to, let me grab this. I think the other thing that we need to deal with is what are the budget ramifications? If people are not seeing us, but only in an episodic manner, what does that mean to our emergency room? What does it mean? Because it may well lead us down the path of saying, I get episodic care because there's not a clinic in my area. I don't come to JPS because I don't have transportation to get there. Those are all questions that we need to ask ourselves in where we go and how we handle situations in the future when it comes to budget questions. The other question that we have to ask ourselves is the utilization. What kind of testing are we providing? What kind of prescriptions are we writing? What kind of ED visits are we having? Do we see a preponderance of ED visits from a certain zip code? What kind of ED visits are we getting from some patient that has seen one of our providers, but then the next day comes back into the emergency room? And then taking that information and overlaying it with heat maps so that we can better understand the medical needs of our community and the utilization trends. And then how do we save money in this process so that we can churn that money right back into expanded services? We can reach out to more people. We can address the people out there that are not in our connection program and get them in our connection programs and better serve our community with a wider net and better care for our folks. And the last question would be, how do we look at the population that is out there that could be a JPS patient but is not? They're not in our connection program. They're not enrolled. How do we create collaborations with groups such as the Federally Qualified Health Center? How do we work better with public health? How do we work with Catholic Charities, United Way, and the myriad of other social services groups that are in the county that we could partnership up with greater than we currently do to make sure that there is a very viable stream that people can come into the JPS Health Network and we can provide them care. So my introductory comments are meant to say we need to look far greater at managing our connection population, how we enhance the connection population, get the utilization of the connection population, and then how we create collaborations in the community at a diligent manner to figure out how we better serve even a wider population than what we currently serve, and get them into preventative care so that our numbers for stage 4 cancer are significantly reduced. The amount of testing that we get for prostate or colon cancer is reduced. How we're attacking and dealing with diabetes, rather than just seeing patients on an episodic measure, how do we get in front of the chronic diseases that we deal with? What I'd like to do now is ask Michael Hochberg to talk a little bit about what we've learned through our DSRIP programs. We have had DSRIP programs that probably have given us some teaching skills and some abilities to apply to our connection program. And then Michael's going to talk a little bit about the importance overall of data and how one cannot make anecdotal or from the heart or guesses in this. It is a data-driven process. So Michael, if you don't mind, why don't you say a few words, and then I'm also going to introduce the third part of our report to y'all.
Great. Thank you, Robert. So first, I'd actually like to start with a brief personal story. So all of you know that I am not a native Texan. Surprise. And that I sadly, I say this with all heart, sadly did not go to Texas A&M or the University of Texas. That I grew up in the Bronx. What you probably don't know is that my dad drove a New York City taxi cab in the 1980s in order to help support our family. And 1980s New York City was not heaven. My mom worked at our local hospital as a lab technician, and they scraped and saved every last cent so I could be sitting here in front of you today. Up until the age of 10, we lived in a very small, cramped apartment in a rundown inner city apartment complex. Part of the reason why I am so hard charging, direct, is because I passionately, deeply believe in the imperative of health outcomes, in quality and value, because in another time, in another location, my parents could have very easily been a connection enrollee. We can do better. We are doing better, and we must continue to absolutely do better. Which brings me to where we are today as we further develop the infrastructure to manage our connection population as a true distinct population and understand the lessons we have learned and implement through, as Robert said, DSRIP, but also through our physician KPIs and even the workings of our revised quality committees, all of which are highly, highly focused on being proactive, on risk assessment, and identifying vulnerabilities for our connection populations and all others who utilize our health services. Ultimately, as we think of outcomes, they are intimately tied to the investments we make in the determinants of health, and that includes medical, social, environmental, and the improvements we achieve in variation in all its forms, and that includes cost and quality and clinical. Variation leads to poor outcomes. So then what are these real lessons that we have learned and achieved? So number one, it is clear and unequivocal that physician collaboration, leadership, and partnership in a dyad relationship is paramount to success. There's no doubt, certainly over the last couple of years, last year and change, 2 years, 3 years, we have seen that. Having physicians at the table, driving process, driving protocol, being in a partnership, dialoguing, brainstorming with our operational leadership and our financial leadership allows us to achieve really that true trifecta of understanding our populations and managing and developing new clinical delivery services and mechanisms. Number two, to Robert's point, clean source of truth data is central to any initiative. And by source of truth, what I mean is really one source. If you've got 4 different reports giving you 4 different data elements, that just breeds chaos. So one source of truth data. And data and analytics are certainly not the panacea. They work in the background of an organization. They offer real-time situational awareness to advance value and population-based care, reduce disparities across diverse pools of patient populations, and enhance current or form new service lines and delivery mechanisms. And then when I look at data, there's really at the heart of it 7 knows, and that's KNOWS, knows. And really those 7 knows are know your patients, know where your patients come from, know your patients' determinants of health, again, social, medical, behavioral, know the how, the when, the where, and the cost of care offered to your patients, know your system and know your network vulnerabilities, know your harm events, and know what your resources are. Back to those lessons learned. Number 3, education is critical and vital. And that means education across individuals, staff, community, and patients. And education is in and around not just how to improve one's health, but it's education about process and protocol, so everybody understands exactly what needs to be done and how it has to be done. Number 4 is accountability. Clear, concise, demonstrable, and measurable levels of accountability. Number 5, and again, Robert mentioned this, is really about relationships, and that includes outreach and breaking down walls, breaking down silos, having a true sense of togetherness, of oneness. We are all partners here, and those include internal relationships with multiple stakeholders, as well as all the external ones within the community. All of which ultimately leads us to results. And so I'm very proud to share with you some of the results that have come out of DSRIP, as well as some of the results through our claim KPIs, some of which are particularly pertain to our connection population. So on the DSRIP side, and I'm just going to read these off from our DSRIP 2.0. We have provided over 14,000 mammograms to patients in 2019. That includes 150 homeless patients at True Worth Clinic. Stage 4 breast cancer rates have decreased from 14% in 2017 to 7.5% in 2019, while the diagnosis of stages 0 to 2 have increased from 67% in 2017 to 78.5% in 2019. We achieved target blood pressure gold status from the American Heart Association for management of blood pressure. And we increased the percent of schizophrenic patients who are connected to a primary care provider from 53% in 2017 to 72% in 2019. From an acclaim KPI standpoint, so if you will recall, about a year and a half ago, we really installed very robust key performance indicators and service line goals across acclaim. And that in part is where we review and analyze our performance, and we try to mirror the network-wide AIP from a standpoint of building out goals within the various pillars, and then attaching target threshold and stretch achievements to those. And we do this based upon a calendar year, which is a little bit different than the AIP, which is the organizational goals, which are fiscal year. So for calendar year 2019, under the pillar of population health, within acclaim as a total, we reduced the incident rate of JPS connection patients with heart attack and stroke. And this was a combined measure, so we reduced that incident rate. And those OB patients with preterm delivery who would normally qualify for Medicaid from 5.2% in 2018 to 1%. So that represents a real sizable reduction in the incident rates of heart attack and stroke in our connection population, as well as our vulnerable OB patients who previously had preterm delivery. We also reduced the incident rate of post-operative heart attack and stroke rates in JPS connection patients from, it was already low, it was 1%, but in 2018, but we actually achieved a 0% in 2019. So we reduced it from 1% to 0%. Wow. And then across all of acclaim, we had 54 defined quality goals that's developed and defined by our service line. So we've got 8 service lines. And so across those 8 service lines, we in total had 54 defined quality goals. We achieved stretch in 45 of those 54 quality goals, so 84%. Now, obviously, that's not just our connection populations. These are all the patients that we take care of. So 84% of the defined quality goals that we went through and developed within acclaim, we hit stretch target. We hit stretch. And the other example that I would give is in our committee structures. So in our utilization management committee, which is chaired by Dr. Assad, we implemented a protocol and process to safely reduce morning blood draws, which we know drives cost. And then even from a throughput perspective, we instituted protocols to safely identify patients that do not require cardiac monitoring. Something that drives normally healthcare cost and spend. So those two initiatives by themselves are things that have hugely impactful opportunity to reduce total cost across a healthcare network. So that's a really basic overview and summation of lessons learned, of some of our successes. In terms of next steps, when we talk about health outcomes, we have already hired our director of outcomes-based care. Her name is Afreya Brown. She joins us from the University of Maryland, Capital Region Health. We have created and developed the job descriptions and responsibilities for the 12 other FTEs that the board graciously approved in fiscal year 20 for the management of our connection population. As we manage through COVID, we are continuing to look to hire those individuals. We absolutely continue to source and integrate cleaner and robust data. And we continue to build out those teams, multi-disciplinary, interprofessional teams to drive improvement, to understand risk, to understand cost, to be proactive, to reduce vulnerabilities and reduce health disparities across absolutely our connection population, but across all patients that choose to grace JPS with their health and care. So I will stop there for any questions before turning it back over to Robert.
Michael, thank you. I appreciate that very much. What I want to do is we'll certainly have questions at the end of everything as well. It definitely takes a proverbial village. There is no doubt. And there is a village of people that worked in this, from the community health team that Joy Parker heads up to the work that Lauren Poe did with our DISRIP has been pretty phenomenal. One of the things that I think we've been unfair to you as a board is communicating some of those. And I think we need to communicate it better to you as a board by saying, what is the benefit to the patient? It's less about, well, we did this and we did that and we did this. We need to streamline that and say, what is the benefit to the patient and what was the outcome? And I think we're no longer going to give you numbers of how many people are in the connection program. We want to tell you, those that are in the program, here's the utilization, and this is what happened to the people that were in connection. DT and I spoke last night, and DT raised a really interesting point. He said, I think you guys are doing a lot of good work, but I don't think we've tied it all together as well as we should. And I couldn't agree more. The other thing that we've learned in this, as I talk to other healthcare networks and our team and you as a board approve and look at various tools to use, there is not one tool. And everybody wants to have one tool. If we just had this, it would be the answer. There isn't a one answer. And we oftentimes in life look at that. If I want to do this, I want to do this exercise and I'll look this way. I want to take this pill and do this. I want to do these things, but I just want to do one thing. If we are to manage our connection population, if we are to expand our services, if we are to get people out of episodic care and into preventative care, we have a huge amount of reaching out to do to change a person's lifestyle and figure out how we best have significant impact to our patients. So in order to do that, we have some incredible people. One of those people who's incredible is Michelle Haynes. You've met Michelle before. Michelle is energetic. She is talented. We've been lucky enough to have her at JPS for 10 years, and our hope is for a lot more years at JPS. but she's the director of our enrollment and eligibility. And she deals with our connection patients and she takes it to heart. She's done an incredible job at dealing with it. And one of the things that we want to do, which she's going to tell you about, is how do we communicate with our patients to know what we have is right for them? And then how do we communicate with our patients who may have fallen out of the system and didn't come back? And more importantly, how do we talk to all those folks out there who need JPS but are not part of our program? So Michelle, if you would please, why don't you give the board an update on some of the initiatives that you're going to spearhead and the work that you're going to do?
Thank you, Robert. I'll just reintroduce myself. I am Michelle Haynes, I'm the Director of Eligibility. I manage the JPS Connection Program. I've been here around 10 years. And my entire 10 years, I've been involved in the Connection Program in some form or fashion. I am a little bit over passionate about the Connection Program. So if I start talking fast or get a little bit too excited, just wave your hand, I'll slow down. But what I want to tell you is that during my time here at the 10 years, I started out screening. I actually was a financial screener and I actually processed cases. And after that, I went on to audit the cases and then into a leadership role. Well, the best part of my tenure here was the processing cases because I got to be with the patients day in and day out, understanding where they're coming from, helping them get on the program and feeling that joy of them actually being approved and them being excited about that. So I love the interaction with the patients. I'm very excited to tell you about what we have coming up. The last time I think our program was reevaluated was back in 2013. And so we're looking to do focus groups in the community to get an understanding from them if our program is benefiting them the way we intended to. So with that being said, I want to get out of these focus groups. There's certain things that I'm personally looking for. I want to understand, is our program working? Is our program working? Is our application process, is it easy? Is it hard? Is that application, is it clear? Do they understand it? Is it confusing? I really want to understand some of the barriers that they face getting onto our program. Do we ask for too many documents? Are the documents hard to obtain? I ask that question because we have a lot of people applying for action. A lot of people apply, but not everybody finished the process. And that is concerning to me because they'll start the process, but then they don't submit the rest of the documents to finish the process. So I want to understand, are we asking for too much? What's the barrier in them finishing that process? Another thing that I'm concerned about is our enrollment period. We typically enroll for 1 year. Is that long enough? Is that too long? I just want to understand the ins and outs from a patient, a client's perspective on how we're doing. The access to applying. So we have several ways that you can apply. You can fax, email, drop off. You can fax, email, drop off. You can walk in, which pre-COVID we can walk in. Right now we don't have that ability right now, but we do have drop boxes on the outside of our centers. Is that enough? Do we need to up our technology? Is there other things that we can be doing to help people apply more seamlessly? So I'm looking to get that type of feedback from these focus groups. Another thing, which is a big thing for me, is how often are they using the benefits? So we have patients that come in and they do the application, they submit the application, submit the documents, get approved for a year, and don't come in. They do not use their benefits, and that's concerning. We want to know what barriers are preventing them from using the benefits. I do understand that sometimes they go to other area hospitals. We know that we have staff members that sit at our neighboring hospitals that help with the JPS connection to get them enrolled and send them back over here to us for a medical home. But we also, in them doing that, they see a lot of patients that come in that are already connected. So why aren't they using the benefits that we have that they enrolled into? So we want to understand what barriers are they facing. Is it clinic locations? Or is that a barrier? Is it access? Is it transportation? Is it language barriers? We're trying to understand what we can do better, what barriers we can help remove, what opportunities are there out there for us to improve on our program so we can help our community get the care that they need. And then for the, and Robert talked about this earlier, for the patients that do not have connection or had connection, they let it go and never came back. We want to know why. We want to know why. I go out and, well, pre-COVID, I do outreach. You know, I go out with the team sometimes and I'm outreach. I do more of talking than I do with the application process, but I do talk to the clients and some clients are, it's shocking to me that they don't even know about our program. And so what do we need to do better to get the information out about our program, the benefits that we have to help our patients? So these are the things that I'm looking for to come out of the focus groups. We want to just make sure that we're removing the barriers. There's something I tell my team, and I'm trying to keep it short because I know I can keep going and I don't want to bore you guys, but something I tell my team often, and they're probably tired of me hearing that, is that any one of us could be sitting on the other side of that interview table. And so I think it's our duty to make sure when we are helping our patients that we go that extra mile to make sure we're doing everything we can to make sure they get the care that they need. And that's making sure, and that's part of this focus group, making sure this program is intended to work, is working the way it's intended to. Because sometimes we put blinders on, we put something out there, we think, hey, this is great, and then but the patient itself or the client are having struggles that we don't really realize. So we want to hear from the community. We want to hear from our patients. We want to know what if this program is working, the application process. We want to know what's working, what's not working, what opportunities there are. So we want to definitely try to address those so we can move forward in the future. I'm gonna stop there because I know I can go on, and I don't want to bore you guys because I get a little bit too hyped up about connection. So I'm just gonna stop right there. Turn it back over to Robert.
Michelle, thank you. And your enthusiasm, your energy, and your heart and your mind are all what makes that program good. Michelle is frontline. She sees those patients on a daily basis. And that's why I'm so proud of her and excited about the initiative for the focus groups. So what we really wanted to do is let you know that all of us will play a role in this. The community that Reverend Emerson is going to be in from the standpoint of his church is going to reach out to individuals that Roger Fisher may not see when he's running in the work that he does with the city and what he does in his profession. And Zim Zimmerman is going to know people that are going to be helpful to us. So it's going to take a network of us trying to figure this out. We as staff need to tell you as a board what we're doing, how we're doing it, and the tools by which we're going to use that to create efficiencies so we can have cost saving, so we can move more people into the program. And Amanda, you've had such a past in social work and efforts. It's going to be helpful for each one of you to understand what and how and give us your input. But today's purpose, Mr. Chair, was to tell you it is a refocus and also to give some basic questions that need to be asked as we continue to move to the best system for managing our resources and moving into an effort of population health that is more to the preventative care of an individual than it is the episodic care. We'll never move forward unless we do. So, Mr. Chair, we'll be happy to entertain any questions that board members may have, but we wanted to give you that update. And thank you, Mr. Chair, for allowing us to do it.
Any questions for Michelle or Robert or Michael?
I have a couple of questions. First, I want to say thank y'all for the presentation. I would love to get this program results that Michael talked about. We have not seen those. Those were great. I'd love to see that. And Michelle, I am excited that you're doing the focus groups. I think that's a wonderful idea. And ask that y'all look at some of those forms and find out which one are really required. And if there is another organization like Medicaid has some of the same stuff that you're looking at, if they're on that, do they have to go back and prove all that stuff if they have a letter? You know, kind of look at some of that. my other deal is saying, I do think looking at where with the outcomes is a great idea. And Robert, I think this is a good start.
Thank you, Dorothy. I appreciate it very much. Any other questions y'all have?
I think this is Steve Montgomery. One quick thing on the focus groups. Can you give us as we go through those, and I think you mentioned they'll be ongoing, can we get maybe a feedback loop that we get that feedback and we kind of learn about the changes that are made so we can just sort of see the whole process evolve?
Yeah, it's a good point, Steve. What we want to do is be able to conduct these focus groups to answer some of those questions, but to keep them continuous, because it will be a point in time, and that point in time could move, it could change. So we'll keep you all up to date with where the focus groups are. We plan to have those focus groups. We want to get a few suggestions from a few groups on how you do the focus groups in a COVID-19 world. That it's not going to be as traditional as some of the focus groups we've had. But we will do that. We will keep you up to date, and we will also tell you about the continuation of the focus groups.
That's great. Michelle, thank you so much for the presentation, for kind of clarification. I think that a lot of our community is very confused on the eligibility process. A couple of things on the focus grouping, because I've done it. It can be great. It depends on how you do it, as we all know. I would also suggest, if you're going to focus group some of your community partners that are referring your patients to there also. I think that's an important part of what we're looking at, especially with the community. And I will say, a couple of years ago, there was a big effort to kind of create a common application for individuals who need services. And that might be something to revisit with your Texas benefits as well, and how that loops into with our connection patients. That is a huge barrier. I mean, not everybody carries their documents, but I have seen a lot of my clients, they hold on to their documents very, very closely. So, because they never know when they're going to need them and for what place. So I thank you for your passion in working with our connection patients. That is my main thing. I think also you hit it right on the head that a lot of patients and a lot of individuals in Tarrant County don't even know about the Connections program. And it's too good of a program to be this well kept hidden. And especially when we're talking about our prescription programming too with the Connections. That's a major piece for our patients that do not have access to prescriptions on a regular basis. Or even that they know that now with COVID that they can get their prescriptions by mail. So I think there are certain things that we can definitely do and help marketing those kind of things out into the community, that Connections can also reach out to their clients, their patients at that instance as well. But thank you. I think that's all. The only other thing that I had, I know that this is we're going to continue to explore as a financial team, looking at the capacity. I know that's what this focusing group is for, looking at capacity of what within the light of COVID, and that many of we saw this back in 2008 and 2009 when the bubble burst, that individuals of a middle class nature never knew how to tap into benefits before and were inundating offices and case managers and trying to work through that process. So I can see that happening over the next couple of months into the next year as we look at unemployment rates as well, and what that connection program can look like and benefit those individuals as well who've never had to tap into those resources before. Because as you stated earlier, we're all a paycheck away. And so that's one of my major concerns. Thank you so much.
Amanda, that's hugely helpful. Thank you very, very much.
Robert, I'd like to offer, thought this came to mind is with Michelle, is to maybe set up, I'm going to reach out to the pastors to set up maybe a connection fair.
Okay.
Where I will seek, and I'm going to talk to Dorothy about it, to go into Como also. But to just bring the pastors together, it could be 100 and 150 of them. She could present it then, and then we could work a kind of way to have it at that same time. Members could come by, hear the presentation, and then sign up.
That's a great idea. You bet. Thank you. And I know Michelle has done quite a bit of community outreach, and any suggestions on community outreach that y'all have are going to be hugely helpful, because y'all are going to know populations that we may have missed, or we went to one place 3 times and didn't go to another place 1 time. So,
Right.
Reverend, that's very helpful.
Robert, I have one other suggestion on partners. As we reach out to make sure that we are connecting with the city, they have a wellness program and their community service program tie right into JPS connection, and that would be a good reach. But I also want to encourage that we include the county, because I'd like to make sure that our case management and their case management program are working together.
I agree. Okay. Very good. Okay. Thank you.
Mm-hmm.
Mr. Chair, thank you for the time. We appreciate it. And that's given us some great insight. And thank you all for allowing us to make that presentation and giving you some insights into where we're going.
Great. Thank you. Anybody else? Comments, questions for Robert, Michelle? I must, as an aside, when I met with Judge Whitley, which has now been a long time ago, I was there with Steve and Charlie, I looked Judge Whitley in the eye and told him that our system was broken. And that was the classic system of episodic care, and that we needed to move toward more community-based health, wellness, etc. So at least it's out there.
You bet.
Okay, next thing I've got is committee reports and Finance Committee, which is Steve.
Yes, thank you, Mr. Chairman. We had our committee hearing on the 25th. It was just a wonderful committee hearing, just very well chaired. Probably don't get enough credit for how well it was chaired. But we passed on for consideration of the full board a handful of contracts, which are on the consent agenda, which we commend for your approval. We also got the May numbers from Sharon. And I think actually everybody on this call was in that committee hearing. So I would just suggest that Sharon just is available for questions instead of having to run through the whole report again. I think everyone has heard it. If anyone really desires to hear it again, I'm sure she'll do it. But that's my report, Mr. Chairman.
All right.
Do we have the opinion from KBB yet, Sharon?
I'm sorry. Yes. I'm planning to have
Sharon,
you are. Yeah, Sharon, it appears that you've decided to go swimming. You're totally underwater.
Is that better?
No.
Now it appears that you've been attacked by aliens.
Yeah.
I'm not quite doing that.
On your phone.
Yeah, why don't you try another system, or ask the aliens to quit doing things to you, because not in a good situation. We can't see you, and that may be good.
I see her, but maybe try on your phone, calling in on your phone.
Just calling on your telephone.
Hey, Sharon, I will text you the phone number if you don't have it.
Okay, if I turn my internet on, my voice is very better.
Whatever you said is not better. So don't do that anymore.
It's the helium.
If Sharon doesn't present a report, do we just accept it or approve it? That's it?
I believe that's correct, Dorothy. Yeah, I think we
just accept it. Okay, all right.
DT, what we can do is we can get back to you on your question regarding the auditor, and we can either take that offline or do it later in the meeting, either which way. So, but I got the question, and Sharon will know the question. We just can't obviously hear her.
That would be more than efficient. Thank you.
Okay, thanks.
All righty. Well, everybody's had a chance to look at the financial report. Would somebody like to make the motion to approve?
To accept.
Mr. Chairman, I move that we accept the report.
Okay, and who was
Dorothy
that?
DeVoe.
Go ahead, Dorothy.
Suzanne, did you get those?
Yes, I did, but on the financial summary, it's not an approval item. It was just an update.
Okay, well, thank you.
Mm-hmm.
All right, we got Sharon back yet?
Well, I'm in a different location. Is that better?
Yep, it is better.
Yeah.
Okay, so I bumped Roy out of his office from my office. So, DT, to answer your question, I have reached out to Chris Clark with BKT on the 2 issues that were brought up in Finance Committee. So he is going to join us in a couple of weeks at the Finance Committee to have a dialogue with the board, both on the COVID monies and the way that we treated them, and also on the acclaim forgiveness of debt. I think those were the 2 questions that I'd ask him his assistance with.
Okay, that would be great. Thank you.
You bet.
All righty. Any other questions for Sharon? All right, thank you. All right, Roger, Governance Committee.
We had an equally exciting meeting of the Governance Committee. I dare say better chaired, but no, we met. On the consent agenda is PRV 200, which is access to medical records, and a policy for approval on the consent agenda, as well as the approved in committee standard operating procedures document. We did all the changes that were requested in the committee. That is also on the consent agenda. I'm going to be putting together a small working group on that we can work on the policy regarding MWBE participation. And then pretty soon the committee is going to get working on the, I'm just drawing a blank on our board. What is it called, Amanda?
Bylaws. More bylaws.
The bylaws. Yeah, that's what I was looking for. Thank you, Neil. Sorry. Other than that, we're chugging along. Thank you, sir.
Okay, I think we have to approve the board standard operating.
Yeah, you do. You do.
Right.
Yeah, those PRV 200 and the standard operating procedures are in the consent items.
Well, the procedure is, but the standard operating procedure is there for a vote since we were coming back with committee recommendation.
Oh, okay.
Roger, you just want to make a motion to approve?
Sure, I move to approve the standard operating procedures.
This is Zim. I'll second.
All righty. Any discussion? All in favor, please say aye. Those opposed, raise your hand.
Aye.
Okay. Now we're down to the consent agenda. 4 items. Somebody like to make a motion to approve?
Approve.
Okay. Reverend Emerson, Suzanne made the motion and Zim seconded. Any discussion? All in favor, please say aye.
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 The next thing I have on the agenda is the ratification of emergent matters approved by officers of the Board of Managers. And the first of which is, and we approved these on June 17th. The first is GE Monitors, JPS Surgery Center, Arlington.
Mr. Chair, if you don't mind, if I could interrupt just one quick before y'all approve these from the full board. I want to make sure that we're doing you all the best service, and I want to coordinate through Neil's office and with staff. I think sometimes you 3 members of the executive team and officers just get something in your email box without maybe the best of notification. So some of these emergency items come up quickly, but I want to make sure that along with the notification that Neil sends out, that you all get better clarification of what these items are and what the details of them are. So I think we got to do a little bit better at right hand and left hand, because Neil does a good job of getting information out to y'all, but I think sometimes it's not accompanied with the background material that y'all need. So we as staff are going to do better in the future so that you three members are not just getting a request, but you can see an itemized reason for that request and why it's being considered emergency. So I want to make sure that we alleviate those challenges in the future.
Robert, I appreciate that. I also appreciate Neil's team and you and your staff. I had asked that we provide any questions and email correspondence back and forth to the full board so that everybody can see that we are very thoughtfully going through these and thinking about them. And I think that that's just for transparency, not only to the public, but to the full board to understand that we believe that we're asking the same questions that any one of you would ask in response to one of those emergency measures.
Yes, sir. And I appreciate that. I think that would be really good. These have come up quick, and it's part of the nuances of the world we live in right now, but I think we could do better. So we'll coordinate through Neil's office, and we'll have the staff better at dealing with this. And then we will include questions so that when you initial three members see it, you have more information. And then when the board in its totality sees it, they'll have better information.
That okay with everybody?
Thanks, Robin.
Yes, ma'am.
Okay. We have to ratify the first one, which is the GE Monitors JPS Surgery Center, Arlington. If somebody would like to make the motion for approval.
Move approval, DT.
Second, Amanda.
All right. Any discussion? All in favor, please say aye.
Aye.
Those opposed, raise your hand. Say aye. All right, that one passes.
Mr. Chair.
Yes, sir.
We approve the financial.
Oh, yes. You are correct.
All you need to do is have a motion to accept the financials presented.
I believe we had a motion and a second already on that.
Yeah,
I don't know that we voted.
I think I moved and Dorothy seconded.
Yeah, I don't know that you voted.
Yeah, you're correct.
Okay. We've had a motion and a second. That's totally my fault. Any further discussion? Then I would hear a motion. Vote for approval.
Aye.
Aye. Aye. Anybody opposed? All right, that's passed.
I think the vote is acceptance.
Acceptance.
Yeah, it's acceptance.
Acceptance of the committee report of the Finance Committee. Then the next thing I have is the Ballaster. Is that how you pronounce that?
Correct.
Report. Everybody, I think, got it in advance with the questions.
Right.
And if there's no discussion, entertain a motion to approve.
This is Charlie. I'll make the motion, Chuck.
Okay. Is there a second?
This is Zim. I'll second.
Jim seconds. Any discussion? All in favor, please say aye.
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 Those opposed. And the next one that I have is the interlocal agreement with the city of Fort Worth. And that's for the prescription copay assistance.
I had a question on that one.
Pardon me, Amanda?
I just had a question on it.
Okay.
In the reporting of who is eligible, it didn't outline eligibility requirements for the program.
Yeah, those eligibility requirements, Amanda, are set by the city of Fort Worth. So they determine the eligibility. This partnership, after they determine that eligibility, and identifies those families who would qualify for this copay assistance. That list is sent here to JPS, and those families can benefit from a copay. So again, that eligibility is set by the city of Fort Worth. I will let you know that the program does not exclude those who have third-party insurance, so it is a pretty wide band across those who can qualify. And for the most part, it'll probably be first come, first serve. Currently, there's been about 1,400 families who have applied, and they are expecting that at least half of those will qualify for a $300 copay assistance, and that is a family and not a member assistance help.
Would we be?
I have asked Nicole Showcliffe, who's over our pharmacy, executive director of our pharmacy, to get more details from Fort Worth about eligibility, because I knew that you would ask that, Amanda. And so she is working with them. And as soon as I get that, I will push it out to you.
Okay, great. And then just the other thing that I think would be important is of those identified families that received it, that we have information of demographics and also of location. Making sure that the program is being evenly distributed, even though it is first come, first serve.
Okay, and we will get that information for you because we do get their home address, so we'll be able to slice and dice that for you and get that to you.
Great, thank you.
You want to have that at the Finance Committee meeting at the end of the month, Amanda, that data?
If it's possible, I mean, we've already identified the 1,400 families, so that might be accessible.
Yeah, it'll be about 700 of those 1,400 that apply. But Amanda, I will send that to you as soon as I receive that. And Chuck, if you would like, Amanda, yes, I'm sorry. And Chuck, if you would like, I can send it out to the board members.
Amanda, I think that program comes through their community service programs so that data should be readily available because that's their community service. They go and apply and it's almost an identical application to JPS, okay?
Okay,
all right.
Thank you, Dorothy.
Hey, Chuck, can I ask a question of legal?
Sure.
Hey, Neil, I'm a contractor to the city of Fort Worth. Do I need to recuse myself from this vote?
You're a contractor, but you're not a contractor related to this particular subset of patients, are you?
No.
Okay, then you don't have a conflict.
Okay, thank you.
Yeah. From what I understand, this is part of a larger program that's been in Fort Worth for some time that provides housing, food needs, and now prescription needs, and was accelerated because of COVID financial impact to families in Fort Worth.
All right, anybody else, any discussion for Karen? If not, entertain a motion to approve the interlocal agreement.
I move to approve.
So move.
President Emerson, I'll make you the second. Any further discussion? All in favor, please say aye.
Aye.
Those opposed, same sign. Hearing none, motion passes. And the last thing I have is the report of legal counsel, the report of contracts negotiated on behalf of Tarrant County Hospital District under $500,000 for the previous
Mr. Chairman,
month.
Mr. Chairman, for the month of May, there were 37 contracts. Those have been noted. Okay. I have nothing for executive session.
Mr. Chairman, the one thing I did want to announce, the judge just texted me and the governor, to the point Charlie made earlier, the governor changed the policies for elective surgeries in over 100 counties in Texas. For those of you who might not be from Texas, Michael Hochberg, we have 254 counties in Texas. And the one county, or some of those counties that did not get changed, is Tarrant County. So the governor did not make any changes to Tarrant County's ability to continue with elective surgeries. And that certainly speaks to Tarrant County. I know my colleagues are watching very, very closely and pre-testing everybody prior to coming in for surgery, as well as we do for COVID-19. But we've held those numbers. So our policies for elective surgeries, at least community-wide, will not change. I know that others are looking at it closely to make sure that we do what's right. But I did want to give that announcement. Thank you, Charlie, for mentioning that. But like I said, I just got that notice.
Neil, I have a question for Neil. Neil, I think you have a contract listed under their number 36. We approved that in May, and it's more than the 500,000. So I think it's just a typo. Okay.
I'm looking.
It's over 500,000.
We did. We did approve that.
Right.
Yeah. In May.
I didn't catch that. Thank you, Dorothy.
Okay.
Right. All righty. Any other comments for Neil? I don't have anything for closed session. Does anybody else have anything they want to bring forward?
Dr. Hurd, do you have any privileges or anything else that needs to come before closed?
I do have to present them and then, of course, in open session, ask for an action item.
Yes, ma'am. That's what I thought.
Okay, so we do need to go into.
Yes.
And Dr. Weber, we were going to hear from Ron Skillins.
Oh, okay. I didn't have that on my agenda. Is that okay, Neil, to go ahead and hear?
If it's a risk-related issue, yeah, it's already identified on one of the generic closed session items.
Okay, then let's take about a 5-minute break, and then we'll come back.
Okay.
Deal with these. We'll take it's 15, 16 hours, and we'll come back in 5 minutes. Okay, I'd like to reconvene in open session for deliberation and or action deemed necessary regarding any matter listed on the closed session agenda. And that would be privileges. Cheryl?
Thank you, Dr. Weber. As discussed, just need a motion to approve the privileges as presented in closed session with extraction number 96.
Steve Simmons, so moved.
Zim, second.
There's a motion and a second. Any discussion? All in favor, please say aye. Those
Aye.
Aye.
opposed, same sign. That's all I have on the agenda. And if we don't have anything else, we're adjourned at 15:34 hours.
All right.
Thank you.